We actually worked on a machine learning prediction model for thrombosis and polycythemia vera. The motivation for that is because the current risk stratification in polycythemia vera is really a simple one that's binary based on whether or not the patients are over the age of 60 or have had a history of thrombosis. And that kind of stratification really assumes a fixed or an unchanged risk over time, and it doesn't help dynamic prediction. So in an effort to try to develop a model that can be personalized to the patient and dynamically predict the risk of thrombosis in PV, which is very important and certainly a complication of PV that we see and can be a serious complication. So these are some of the reasons we developed this model. And the model utilizes not only machine learning, but actually a very rich and high-dimensional data set that we are able to automatically obtain from electronic medical records. So using an informatics-based system that we have, we're able to really generate millions of data points from the follow-up that we had on about 470 PV patients across many clinical visits over the average of 10 years of follow-up that these patients have had. So by aggregating all available clinical data on these 470 patients over that period of time, over 8,000 clinical visits with hematology, we're able to generate millions of data points that we can then feed into a machine learning model that uses all that information to predict whether or not somebody would have a blood clot or not who has polycythemia vera. So this is unique in a sense that it's the first time that we actually have such a model in polycythemia vera that utilizes such rich data. And the nice thing, too, about this model is it's applicable at any time, it's personalized to the patient, and it uses real-world data that is generally available and in the real world can be applied. What this model has shown us is that the more information that you have in this model, the more accurate you can make a prediction. So it's not just about associations of variables with the thrombosis outcome. It's actually making an accurate prediction based on all that information that's available. And so that model performed very well with a AUC, area under the curve, in an ROC analysis of about 90%. And that's much better than the current stratification model. And it's better than using any single variable by itself. Now, of course, the number of variables in these models are very high because we use a lot of clinical data. And so the idea is eventually to make this a more practical model by combining a few of the top or most important variables. So perhaps a combination of 4 or 5 or 6 variables that perform maybe not as good as the full model, but perform closely enough that it can be practical, applied in the clinic, and actually be predictive. But eventually, I think these models that we've developed have to be validated in using external data sets, but also have to be validated in a prospective study for it to be established as something that would guide our standard of care in polycythemia vera.